Good evening, dear viewers. I, Dr. Shreyas S., consultant Ayurvedic obstetrician and gynecologist, welcome you all to the EVECARE, an interactive webinar for obstetric and gynecology enthusiasts. This is a platform where the common obstetric and gynecological clinical conditions are discussed according to both the sciences. Last week, we had an excellent session on the role of immunity in OBG. We had two experts, Dr. Srimati Raman and Dr. Lakshmi Priya De ma'am, explaining us about the role of immunity in OBG. Today, let's discuss on the most common clinical condition which we encounter in our gynecological OPDs, that is PCOS or polycystic ovarian syndrome. And our today's experts are Dr. Aruna Muralidhar, Senior Obstetrician and Gynecologist at Fortis Latham Hospital. Madam, welcome you.
Thank you very much. Indeed, a pleasure to be with all of you this evening.
Yes, thank you, ma'am. And our next expert is Dr. Vaheeda Rehman. Madam is Ayurvedic gynecologist at Government Ayurvedic Dispensary, Pattanamthitta, Kerala. Madam, welcome you to the show.
Thank you very much. With pleasure.
Thank you. Thank you so much, madam. We had a pre-released video of PCOS where both the speakers elucidated their views and their clinical experiences in PCOS. We had got a lot of queries in the comment section, and we have handpicked few of them, and due to the time constraint, selecting or asking only few questions, not waste much more time and go begin the question answer session. So the first question is to Dr. Vaheeda. Madam, this question is from Dr. Jyoti Dalal. See, we have understood the basic physiology or pathophysiology of how the PCOS is happening, and that has also, paved the way for, to understand PCOS, how to understand that in the modern system. But what do we have it in Ayurveda? Or the question is like, what is the perfect Ayurvedic correlation of PCOS?
Hello, dear doctor. There is no direct mention of PCOS in Ayurvedic scriptures, but we can correlate according to it symptomatically. So we can correlate like Pushpakni Jadaharani, that is Vradha Pushpamdu Yanari, Edhagalam Prabhashari, Stula Lomasha Ganda Sabi, Pushpakni Sabi Revadi. This having the clinical features of PCOS like anovulation, oligovulation, etc. things, and stula, that is obese PCOS, and Lomasha Ganda with hirsutism, etc. So we can correlate with the Pushpakni Jadaharani. The other Yoni Vyabat and Nashtartava like Vanjada, etc. can be the complications of PCOS. So we can only symptomatically correlate this condition because this is not a single disease. It is a group of syndromes having so many symptoms. So it can be, it cannot be directly correlated with a single disease. It can be correlated with the Nashtartava, Artava Nasha, Lohidakshaya, and Abiloma, etc. And the most perfect correlation is with the Pushpakni Jadaharani. Okay.
Yes, thank you, ma'am. So you said Pushpagni Jataharini could be considered to the somewhat, we can consider, though not perfect, but up to some extent, Pushpagni Jataharini, and it is a syndrome, as you said, collection of clinical conditions together manifesting as PCOS. Yes. The next question is to Dr. Aruna, madam. So the question is from Dr. Vidya KP. Madam, generally we see this insulin resistance to be a common denominator for most of the metabolic conditions, so as PCOS. So the next question is something like that. Dr. Vidya KP has asked, what causes insulin resistance in PCO? Aruna, madam.
Okay, yes, absolutely. That's right. Dr. Vidya, thanks for your question. PCOS has two main metabolic determinants, basically. One is the insulin resistance, and one is the hyperandrogenism. And both of them are correlating, and both of them are interrelated. The key contributor to metabolic disturbances is the insulin resistance, right? And basically, the hyperinsulinemia, the hyperglycemia, and the oxidative stress, they in a chronic form act on the ovaries, and then the ovaries start producing androgens, and that itself will sort of cascade the whole process. So it's insulin resistance is a genetic uh, abnormality which is existing in the lady, and that cascades the events to make it a complete syndrome of PCOS. So that is a basic underlying metabolic problem in these women, and that's why we see it more in in running in families, those with a family history of diabetes, PCOS, and infertility, etc. It runs in those families. I hope I've made myself clear. Thank you.
Yes, ma'am. Yeah. The next question is something with a clinical presentation, and Aruna, madam, the question is for you again.
Mhm.
This question is from Dr. Chandini Chandran. Ma'am, what is the management of menorrhagia caused due to PCOS, and what might be the cause?
Sure. That's one of the really, difficult problems that these women come in with. So the menstrual irregularities may be one end of the spectrum, but those with the menstrual irregularities, especially the ones which are having chronic anovulation and a very long cycle length, when they do have the period, it tends to be a very heavy, protracted bleeding. And that is because of the unopposed estrogen, which is there in the system. The unopposed estrogen builds up the endometrial lining. The lining gets thicker, and then when she actually has a withdrawal, the bleeding is excessive because the entire endometrial shedding has to take place. And for this, that is a basic cause. And the treatment, basically the management will completely depend on several factors. The most of the common things that we see is, in very young people or those who have contraindications for using contraceptive pills, etc., we may use cyclical progestogens. So we have cyclical progestrogens, which we give from day 16 to day 25, and at least they have regular cycles. And this heaviness can be prevented because there is, the endometrial lining doesn't build up. Similarly, we can give her low dose contraceptive pills with a good combination of progesterone estrogen, which will help her have regular withdrawals. It's very important that these ladies have at least 10 cycles a year, so that the endometrial lining doesn't build up too much and cause atypical cells and heavy menstrual bleeding. The other ways of treating this, especially in somebody who desires contraception or who is completed their family, is putting an intrauterine system, which is also called Mirena, one of the famous brands, popular brands, which basically controls unopposed estrogen and keeps the lining thin. So there are various ways of dealing with it depending on the individual. Thank you.
Yes. Okay. Thank you, madam. Can we have the same counterpart from our Ayurvedic sciences for menorrhagia, Dr. Vaheeda, madam? For menorrhagia and PCOS, your clinical experience.
Yes, it is the most complicated case, that the menorrhagia in PCOS, because like Aruna madam says that it is unopposed estrogen or the endometrial lining is more due to the chronic anovulation and chronic oligomenorrhea. Here, according to Ayurveda, the Sukshma Kesha Pradigasha Bija Rekta Vahasija, that is the accumulation of the endometrium in each month, should be washed out in each month. Otherwise, it will cause the accumulation and cause the menorrhagia, because the curly circular hairy-like arteries lose its anatomical structure due to the addition of the endometrial lining. So there is a thick plaque coming out during menstruation, or once a while the female get menstruated, causing the menorrhagia. So the management in Ayurveda is like that. Madam says that to produce menstruation in each month, or at least withdrawal bleedings once in 2 months. Otherwise, there may be addition of the endometrium. So we Ayurvedic people use for the withdrawal bleeding like medicines that like the Pulingurambu Churna, Panjavolasava, etc. for the withdrawal bleeding. and then correct the menstrual cycle. That is for every 28 to 35 days, there should be menstruation. So we give the medicines rather than the ossipils. We never use the ossipils, but we give the medicines like Saptasaranga Kashaya, Nimbadi Kashaya, etc. for the correction of the menstruation. Ether for liquid is also, and the tablet is also very good for the correction of menstruation in each and every month, which will prevent the menorrhagia after that. Once the menorrhagia get more complicated, we cannot stop it easily. So we can use our treatment principles like Nasya Karmana Rudur Vyabhadyade or Yoni Vibhasishyadi. So we can use the Nasya of Vashaswarasa or Durvaswarasa, etc. 8 drops in each nostrils for 3 consecutive days, which stops the menstruation or the menorrhagia. And then we have to correct the PCOS with our other medications and follow regular bleeding occurring. That is the way.
Okay, thank you, ma'am. Yeah. So this is your experience, your clinical to doctor. Question is from having PCOS and hypothyroidism. How it, Aruna ma'am?
Hello. Yeah, I think there's a bit of disturbance, right? Okay. So I think if I heard you right, you're asking me about a lady wishing to conceive who has PCOS and hypothyroidism. Is that right?
Yes, exactly.
Okay. All right. So that's a very bad combination, really. Somebody with PCOS and hypothyroidism essentially has a lot of weight-related issues, increased adiposity, and because of the way the metabolic, and endocrinological things interact, this is a lady who will find it very difficult to lose weight as well. But if she is wishing to fall, pregnant, to conceive in the, near future, I think I would start with basic lifestyle changes. As I discussed in the PPT, it's very, very important that she starts off with basic lifestyle changes, try to lose weight, try to get her, carbs down, smaller portions, some sort of cardio exercises, so that she can at least lose inches around her waist. So the adiposity has to come down initially. And there's enough research to say that even 5% of weight loss can improve fertility tremendously. So I'll start with that. But suppose there are other factors to consider. For example, her age, or the fact that there's a lot of social pressure, whatever it may be. Then in that case, I would like to aim for a TSH to be less than 3, right? So she may need hypothyroid medication depending on the level. And also the second thing is, if she is having anovulatory cycles, then I probably would be thinking about ovulation induction if the lifestyle changes didn't work. So it all again is individualized, but ovulation induction and thyroid replacement would be my the way to deal with it. As Dr. Vaheeda said, I think it's very important to understand that menstrual regulation and fertility treatment, although they do go hand in hand, just regulating her menstrual cycles will not help her conceive, because the egg is not released. So although she is shedding her endometrium, the egg is not being released if we just give them, progesterones or the Ayurvedic medications. So it's important that we actually stimulate the ovary and get one dominant follicle to form so that she ovulates and then can conceive. So that would be my, second step after lifestyle changes.
Okay, so you say that lifestyle changes initially is indicated in such cases in hypothyroidism, and later on try to induce the ovulation or ovulation induction. Yes, right. Yeah. Vaheeda, madam, your view on this PCOS with hypothyroidism?
Yes, the PCOS and hypothyroidism both are the metabolic disorders. So, as Aruna ma'am says, lifestyle modification the first and foremost thing. The lifestyle modification and should be done according with the weight loss, exercise and regular exercise, and cut short of the carbohydrate diets, etc. Then, if she is on hypothyroidic medicine, please never stop the medicine, because pregnancy needs double dose of thyroxine. So she should be in the on medication. Then please check for any thyroid peroxidase antibody like things in her body. If it is there, then it can be corrected with our Vaishwanara Churna, etc. For the accumulation of doshas, we can correct that type of medication. And then we have to induce her ovulation. According to Ayurveda, with the regular menstruation, rather than the modern or the OC pills, Ayurvedic medicines having regular shedding of endometrium or regular menstruation have a capacity to produce ovulation, like Tilakwadha, etc. We can induce ovulation rather than the OC pill, sorry, the hormonal ovulation stimulation. There may be ovarian hyperstimulation. But our medication have good results in the ovulation induction, like Tilakwadha, Tabu, Vellere, etc. And we Vellere in relation with the Sandala Aishwarya, that the major rasayana, of the Sandala, Manduga Bunny, which will correct the hypothalamo pituitary ovarian axis and produces regular ovulation. Then we can treat the case with the first lifestyle modification, then going the thyroid medicines as she needs, and should keep the thyroxine level around 2.5, etc. Euthyroidism level. And if there is any TPO antibody elevation, we have to give medicines like Vaishwanara Churna, etc. for reducing the toxicity in her body. Then we have to induce ovulation like Manduga Barni or Vellere, etc. or Tilakwadha, etc. And by monitoring the ovulation, we have to give advice for the proper conception.
Yes, thank you. You in fact told about a small home remedy also, like Manduka Parni, that is Brahmi or Manduka Parni, which would act on hypothalamo pituitary axis. Madam, Aruna ma'am, are you quite aware of that small herb?
You're talking about Brahmi? Brahmi I'm aware
Yes.
of. Yes, I'm aware of Brahmi. Yes, yes.
They do a chutney out of that in South Canara.
Yes, yes.
Have you tasted
right.
that?
I haven't tasted it. Yes,
that's PCOS here according to Vaheeda madam.
Okay. All right. Yeah.
Yes,
interesting.
Yes. Okay. So we have seen the PCOS as two clinical presentations. The PCOS, so they could present as a lean PCOS or they could be an obese PCOS. So which we have seen. So the next question is from Dr. Aishwarya Narayan. It is to you, Aruna madam. What are the different treatment aspects which can be adopted for obese and lean PCOS?
Yeah, very good question. Thank you, Aishwarya. So essentially, the most important thing to understand, I mean, first of all, the myth has to be busted that all PCOS are obese. Absolutely right. So there is a lean PCOS, there's an obese PCOS. The obese PCOS seems to be a more common variety, whereas if you have, as I elucidated in my talk, if you have 2 out of the 3 criteria of the Rotterdam criteria, so we have either irregular cycles or a polycystic ovarian morphology in the scan. And the third thing is hyperandrogenism, right? So if 2 out of the 3 are there, even a lean PCOS, even a lean girl may qualify as a PCOS. But the most important underlying metabolic problem differing in these two is that lean PCOS have a higher insulin resistance. They seem to be more prone to develop insulin resistance and its consequences, including type 2 diabetes. So this is probably related to the internal visceral fat that lean PCOS tend to have. And they also do have a very strong familial disposition. So when we have lean PCOS, obviously the weight loss aspect doesn't come in, but I still advise lifestyle changes in terms of their dietary changes, and getting more fitter, doing moderate exercise and all that. So that doesn't differ. However, I will look into metabolic aspects because these are the people with poor metabolic syndrome. I'll look into the metabolic aspects and do the baseline test for that, and just educate them about this being a lifelong problem, and a yearly blood sugar tests have to be done because these are the people who might develop type 2 diabetes. And lean PCOS, I've noticed, are a little more difficult to treat in terms of fertility as well. So I think the main differences between the two would be investigating lean PCOS further, more strictly and more, in terms of the metabolic problems. And the obese PCOS, also need investigation, but they need to focus more on the weight loss aspects. In terms of the ovulation induction, again, it's a trial and error. Initially, lifestyle changes, and then I'll probably choose something which will not cause ovarian hyperstimulation. So follicular monitoring and a controlled stimulation of the ovaries, controlled ovulation induction would be ideal in such situations. So that is the main thing that I wanted to bring about to you.
Okay. Yes, ma'am.
Thank you.
Thank you. So now could we ask Dr. Vaheeda, madam, to share her experience with lean PCOS and obese PCO?
The obese PCOS and lean PCOS. Obese PCOS are Sukhasadhya PCOS that we can treat easily with the weight loss, as Aruna ma'am said that. And the most complicated PCOS is lean PCOS, because lean PCOS we cannot do any further weight loss, but we can do the metabolic correction in both the cases. And in obese PCOS, we can treat with Abhadarpana Chikitsa, Lenghana Chikitsa, Adhistaulya Chikitsa, etc. But in lean PCOS, we can treat with the other way of treatment, like the stimulation of hypothalamo-pituitary ovarian axis with major rasayana, etc. Because according to my practice, it is evident that the obese PCOS have not much hormonal irregularities, but the lean PCOS has much more hormonal irregularities. So the hormones and the lean PCOS are very much stressed, and stress is one of the main factor for the lean PCOS. So by giving Dhidhairyatmadivijnana and the drugs acting on higher mental functions like hypothalamo-pituitary ovarian axis, like Nasya and Kalyana Kashaya, Kalyana Krida, etc., we can do for the management of lean PCOS. And then we have to do ovulation induction with the Medhi Rasayana, like that of drug. But in obese PCOS, the weight loss may restart the ovulation, or the weight loss may give further ovulation, or we have sort of medication for the treatment of obese PCOS, like Udvartana, the treatment procedures like Udvartana, fat weight loss and fat reducing measures. And there are so many medications for obese PCOS, but the lean PCOS, the medications are short, and the most important is to clear the hypothalamo-pituitary ovarian axis with the Medhi Rasayana, like that of drug. That is a two different treatment in according to Ayurveda. The Sandharpanothat PCOS or the obese PCOS can be treated with the Abhadarpana Chikitsa or Lenghana Chikitsa or Adhistaulya Chikitsa. Otherwise, the lean PCOS can be treated with the drugs act on the hypothalamo-pituitary ovarian axis or the basic hormonal function.
Oh, yes. Yes, ma'am. Thank you. And the next question is also to you. We also know that you have a credit of treating 1,500 infertility cases successfully. We have heard a lot about that. And this question goes there, madam. This question is from Dr. Jyoti Dalal, a patient with PCOS, and she wants to conceive. What is the line of treatment, ma'am, rather than OCPs?
Yes. By God's grace and the blessings of our gurus, the result outcome occurred. And then the question is, the lady with the PCOS wants to conceive. First we have to select, is it obese or lean? If it is obese, we can move the treatment like Abhadarpana Chikitsa, and first advice to the metabolic for the metabolic correction and weight loss, etc., with a regular strict diet and good exercise. And then ensure proper minerals and vitamin D, etc., are having them. And then please advise with the Udvartana like therapies and weight loss therapies. Then we have to monitor the ovulation by follicular study, etc. And for that, we have to give Tilakwadha or the Valerie tablet. Valerie, nothing other than the Mandugabani. Then we have to monitor the things. Otherwise, if there is ovulation, conception may take place, but the complication of PCOS in after conception, there may be early abortion. So for preventing early abortion, we have to monitor the follicular size, and we have to monitor the ovulation correctly. Then we give the message for conception. Then after conception, we have to protect the zygote or the fetus. So we have to give the Rajanyadi Churna with Balasarpis, etc., and Lakshmana Palkasha, etc., for preventing the early trimester abortion. And also for the metabolic correction, we should the lady should be in the proper advice by the Vaheeda. Then for lean PCOS, if we think there is lean PCOS, then with the Dhithairyatmadi Vijnana and proper assurance, we have to treat the patient and give medicines like the Kalyana Kashaya and Kalyana Krida in the morning, and Sugumara Kashaya with the Manduga Barni Sarasa, etc. in the evening for correcting the hypothalamic pituitary ovarian axis, and still monitor the ovulation and give the medicine. And also Saumanasya Garbhadarana Sreshtam is one of the main code in Ayurveda. So the stress is the main factor for PCOS. For both obese and lean PCOS, Saumanasya should be there. So pacify the patients and give proper assurance and treat the patients accordingly. It will give good result.
Yes, thank you, madam. And probably I have also seen personally Dr. Aruna madam giving that Saumanasya counseling to patients, and by listening to you, you would have also advised that good counseling is more than enough what a patient can have. Right, Aruna madam? Am I right?
Absolutely, absolutely. I think there's a saying that whatever will happen is happening, but while the patient is healing, all we have to do is amuse the patient, and the nature will take care of the healing.
And you do that. And I have personally seen you doing it.
So yeah, that's true. That's true.
Yeah. The next question is again. OCP is not only solution for PCOS, clear, but in general practice, we see doctors prescribe the OCP. Could you hear me, madam?
I could. Yeah.
Was I clear?
Yeah.
In general practice, we see doctors using OCPs with some digestive tonics. OCP with some digestive tonics to treat PCOS. So what is your view on that?
Okay. Every patient who comes into our chamber for a consultation is different. I mean, you cannot compare one patient to another and say, I'm going to give a blanket treatment to everybody. So every lady who comes in, PCOS is common even in a 15-year-old, a 16-year-old, 17-year-old, and it can go on till, the lady reaches menopause. So it's not like a patient, a lady has pregnancy, and then later she'll never have PCOS. So even post-pregnancy, the PCOS can come back. So it depends on what kind of a lady is coming to seek advice. What's her family, whether it's completed or not? Is she desiring fertility? What are her main symptoms? So it's very important for us to spend some time in understanding what her main symptoms are. And depending on the symptomatology, we have to guide her. Yes, lifestyle changes are the lifestyle modification, TLC, tender loving care, a lot of counseling. All this forms the platform. But beyond that, it's very individualized. I wouldn't advise OCPs to everybody. Similarly, there are some situations where I have to prescribe OCPs, especially if the lady is having once in 6 months cycles, and is also seeking contraception, for example. So in such situations, yes, I might take that as the first choice. Also, before prescribing OCPs, please be very careful. Whoever is prescribing OCPs, please look into the contraindications, look into the risk factors, especially an obese lady. Nowadays, it's not surprising for me to see actually smokers coming to my chamber. Obese lady, say smoking, with a very strong family history of hypertriglyceridemia or having hypertriglyceridemia, and having a very poor lifestyle and being a couch potato. These are the women who might not have the best results from the OCP and may have a unfortunate side effect or an unfortunate complication of thrombosis, which is clots in the veins, which can be very dangerous to her. So before prescribing OCPs, I myself would, basically individualize the treatment, also get a serum lipid profile done as a baseline, and, make sure what her lipid profile is like, whether she has any family history of thrombosis, what's her risk for thrombosis, and then prescribe it. Also, OCP is not one blanket term. Combined oral contraceptive pills is a combination of estrogen and progesterone. And the estrogen can be as low as 10 micrograms, it can be 20 micrograms, it can be 30, it can be 50 micrograms. And also the progesterones, there's so many different progesterones, first generation, second generation, third generation. So it is important to individualize and give her the exact combination, permutation combination of the OCP for her symptoms. For example, if somebody has essentially hirsutism or hyperandrogenism, in such situations, you might want to give a combination of a low dose estrogen with something like drospirenone, or that sort of a combination, in order to reduce the testosterone levels. Or that sort of changes have to be done, and it's very important that you know exactly what to prescribe. Plus, yes, you're right saying OCPs are not the only treatment. There are so many other medications in our armamentarium. Now I'm learning about Ayurveda, also very enlightening. But there are things like, just basic vitamin D supplementation. Most of PCOS women have vitamin D deficiency, as you must have observed. Also check for any thyroid issues. Also myoinositol and chiroinositol combinations, they also help in reducing the metabolic dysfunction. Also metformin, oral hypoglycemic agents like metformin, which is insulin sensitizing. So that may help in certain type of individuals. So it is all a matter of a little bit of individualization. So OCP certainly is not the only treatment. And in fact, some people may not need OCPs. Just the other kind of treatment would suffice.
Yes.
Thank you.
Thank you, ma'am. Thank you for sharing your views on that. And as we were discussing, viewers, there are a lot of measures, a lot of treatment procedures which both the systems can offer. And particularly Ayurveda, when speaking, we've heard more of Panchakarma. And probably in clinical practice, we see that a patient is subjected to either Vamana or Virechana. And one part is often not spoken much of, that is Nasya. And Vaheeda ma'am, you were mentioning about Nasya, and the next question is from Dr. Sunita Rana. So Dr. Sunita Rana madam is asking, what is the protocol of Nasya in both the conditions of PCOS, and your particular combinations or your procedure, how you follow in your clinical practice? Could you please share that, madam?
Yes. And the Nasya is also a Panjarma process. Here, for treating the PCOS, we can use both obese and lean, the Nasya, but in different pattern. For the obese PCOS, we can use Nasya for stoppage of Menorrhagia. In obese PCOS, mostly associated with the Menorrhagia. Then we can use Nasya for the stoppage of Menorrhagia that they have. So we can use the Vashasvarasa or Durvasvarasa or the Kshirabala, etc. These drugs, 8 drops in each nostril for 3 consecutive days as Marsha. Then we can stop the menstruation or the Menorrhagia, because Nasya Karmana Rudurbhyabadire. Normally during menstruation we cannot do any Nasya because the Nasya Karmana should prevent the Rudu, or should cease the Rudu. So we never do Nasya. But here during Menorrhagia we want the cessation. So we do Nasya for the stoppage of menstruation in obese PCOS. For lean PCOS or for any premature ovarian failure like condition like that, the complication of PCOS is one of the complications of PCOS is premature ovarian failure. There may not be any menstruation even after they use some sort of drugs, menstrual inducing drugs like that. So we have to work the hypothalamo-pituitary ovarian axis with the Nasya. Here the Nasya, the role is to stimulate the hypothalamus. So Nasahi Shirasodwaram, Nasa Pranamanam Aushadam Nasyam, Shirasi Indriyani Indriya Pranavahani Srodamsi Suryamibhagabaste Samsudani. So we have to choose the drug for correct action in the hypothalamo-pituitary ovarian axis. It may be Dhanyandarangrida or Bhalakrida or the Shatapushpa Taila. These 3 can be used for the Nasya. As Pradimarsha Nasya also is effective for long-standing amenorrhea, to bring the Menorrhagia, to bring the menstruation, not for the Menorrhagia, to bring a long-standing amenorrhea, to bring menstruation, we can use Nasya with the Bhalakrida or the Shatapushpa Taila or with the Dhanyandarangrida, etc. Varanadi Kshirakruta is also good for stimulating the hypothalamo-pituitary axis if the condition of the patient it allows. According as said by Aruna Madam, every patients are not like. Each and every patient have different condition and different avasthas there. Some of the patient having amavastha, some having prabhuda doshavastha, and some having madhyama doshavastha. So we have to treat all the conditions with each and every pattern. So for tatra alpe lenghanam madhyam, madhye lenghanam bhajanam, and prabhude shodhana that if the visitation of doshas are more, then we have to use the shodhana therapy like vamana and virejana, etc. And also the vasti is also good for the treatment of PCOS. Here the protocol of Nasya reveals that I use Nasya for obese PCOS for stoppage of menorrhagia and for lean PCOS for inducing menstruation. So different type of medicine can use. First for the Stambhana therapy and the second for the stimulation of that hypothalamo pituitary ovarian axis for producing proper menstruation and thereby producing proper ovulation.
Yes, yes, ma'am. So we'll have to see the dosha, dosha, anala, prakriti, everything depending upon the person to person, and then decide upon the treatment.
Pradhanam, avasthana vidhanam.
Yes, perfect, madam. Yeah. Now, I guess we have come to the end of the session. We'll take up the last question for today's webinar. And this question, we have seen that PCOS is a condition which has a range of concerns from cosmetic to infertility. So we have discussed a lot of infertility issues. When it comes to cosmetic, particularly the women would have certain depression, anxiety, etc. In fact, infertility could also cause that. And this question, starting, I will ask this first to Dr. Aruna, madam. The question is from Dr. Kajol Jaiswal. So Dr. Kajol is asking, can PCOS cause infertility, depression, and anxiety? And does it affect or leads to any complications during pregnancy?
Thank you, Dr. Kajol, for that question. Yes, PCOS happens to be one of the commonest causes of infertility, but luckily it is the most easily treatable as compared to other causes of infertility, like a male factor or endometriosis or unknown causes, etc. Yes, so PCOS, we know there's a problem and we can, sort of try and help her. So yes, it does cause infertility because of the anovulation. The egg is not released. So because the egg is not released, it's not fertilized, and hence there is no pregnancy. That seems to be the main issue there. Also, obesity contributes. Plus, the other important thing is PCOS does affect emotional, mental status of the woman as well. One, because the body image issues like her, excessive hair growth, acne, making her look like a man, people not, basically involving her, befriending her, ostracization. She feels left out, especially young girls, not being able to find a partner, and or just being very obese. So body image problems, social issues. The other thing is because of their, basically PCOS has a lot of high inflammation status. With the high inflammation status, there are high cortisol levels, and the high cortisol levels itself cause depression and anxiety, as well as neurotransmitters in our brain, the serotonin, the GABA. All these are also imbalanced. So hence, depression, anxiety seem to be very common. And also the risk of suicide seems to be more common in PCOS women. Unfortunately. So this is something that we need to watch out for. So anybody who's coming in with PCOS symptoms where we are making the diagnosis, please ask her at least 2 screening questions about depression and anxiety. How does she feel in herself? In the last 2 months, has she been feeling very low? Is she able to, find interest in what she does? Is she feeling very forlorn? And second thing is anxiety. Is she excessively worried about things these days? Does she unduly worry all the time? So these are the screening questions that you may have to ask. And how does she feel amongst her friends? Does she have enough friends? What's her social circle like? So these are very important that all of us as healthcare practitioners identify, because these are the women who are likely to be having major mental health problems and also self-harm and suicide. One. Second thing is, so for infertility, mental health problems. The last question that you've asked is, what are the risk complications associated with somebody with PCOS having fallen pregnant? As Dr. Vaheeda said, yes, one of the main issues is an early miscarriage. Early miscarriage because of the metabolic problems, may be contributed by diabetes or hypothyroidism. Second thing is that these women are more likely to be obese. So hence, obesity-related issues such as type 2, gestational diabetes, very, very common in PCOS. So these are the risk factors. And we have to screen for gestational diabetes at booking, somewhere around, depending on the values at booking, maybe again at 16 weeks or 20 weeks, again at 28 weeks, and again in the third trimester, because gestational diabetes can come at any point of time during their pregnancy. Third thing is they're more prone to gestational hypertension, pregnancy-induced hypertension as well. Preterm labor seems to be more common in these women. And it doesn't stop there. There are genetic and epigenetic issues with the baby itself. So the baby is under a prolonged, either a prolonged prenatal stress, or the fact that she might develop gestational diabetes with hyperglycemic situation. The baby itself has a lot of changes happening with metabolic issues. So these are the babies who have are macrosomic, lot of fat in their body, difficulty during delivery, have needing more inductions, needing more cesarean sections. These babies tend to be the ones which have low sugar levels after birth, so they have more NICU admissions. Also, these babies may have lesser immunity, more issues with asthma, etc., allergic reactions, and these are the babies who will go on to become metabolic syndromes early in life. So they will be carrying the genes. And also epigenetically, there are a lot of changes which happen. So yes, it is a long drawn, multifactorial issue that we as health practitioners have to be able to control. So these women after delivery also, please tell them to get their sugars checked after 48 hours of delivery, then again at 6 weeks of delivery, and every year thereon, because you want to pick up these women if they're turning type 2 diabetics. Also, their cholesterol levels, vitamin D levels, and thyroid levels and lipid profiles have to be checked. So this is what I would like to say. Thank you, Dr. Shreyas.
Yes, thanks, ma'am. Thank you. I hope the query of Dr. Kajal was solved here. And I guess we'll wind the session for today. We had an excellent, both the experts shared their views and experiences, clinical experience with us on polycystic ovarian syndrome. Thank you, Dr. Aruna, madam, for this, and also Dr. Vaheeda, madam. Thank you so much for elucidating your views on this. And I now ask the Himalaya Drug Company product manager, Dr. Wahid Pasha, sir, to speak few words for today's event.
Good evening, Shreyas. Is this the right time to go?
Yes, you can. Good evening.
Good evening, viewers. I guess we have had a feast of information today from both of our speakers. They've shared their very valuable clinical experiences and expertise with us. I guess there have been a lot of take-home message for all of us today here. I'm sure we are going to apply this in our clinical practices in the coming days. I'd like to take this opportunity with the permission of Dr. Shreyas here and the speakers, yes, please put across a few words. If I may, with the permissions of our both the white speakers today, try to group the discussion into the presentation of PCOS per se. I can probably put three in line at once. The first being the menstrual concerns or issues that are presented, maybe the most important presentation often, if not every time. The second is, insulin sensitivity. I've highlighted this out, but probably, it's got a big metabolic base out there that needs to be addressed as enlightened by both the speakers. Last but not the least, we also need to look into the androgenic outcomes, which can sometimes also be a cause for anxiety. Anxiety can, of course, be a part of it. Needless to say, Ayurveda brings about a whole lot of herbs for each of these issues in particular. But if I may select a few of them for these in relation with PCOS, these are few. Number one is Lodhra and Kanyasara, or otherwise called as Kumari, a form of Kumari as well. These have been used for over centuries in the management of menstrual concerns. They are good menstrual modulators. Kanyas are exclusively seen to regularize endogenous hormone levels and support normal folliculogenesis. Coming down to insulin sensitivity, there is one herb which is in vogue today, and that is methi. It's being touted as a very good herb to address about insulin sensitization and regularizing the menstrual cycle. Needless to say, we are trying to address about the entire metabolic syndrome complex out there. We do have plenty of other products that can be added on here. For instance, LA52DS address about insulin sensitivity. But of course, that forms a different chapter, which I'll share with you in the next coming sessions. Last and very, very important are our anxiety and androgenic outcomes. Mundi and Jetamamsi, two of these herbs have been spoken for use of late a lot. Mundi especially as an anxiolytic and androgen receptor inhibitor. Jetamamsi, a well-known drug for its ability to address about anxiety-like presentations. So at Himalaya, we put all of these together, and what we had was these 5 established herbs, which can be put across to use in PCOS, and that's how our product EVECARE Forte was designed. EVECARE Forte for effective management of PCOS. This also comes with a clinical evidence out there. This is a study done by Dr. Ahalya at Government Ayurveda Medical College, Bangalore. This study has proven that it can improve the hormonal parameters, where we saw a significant reduction in serum testosterone, suggested by the positive outcome. This suggested a positive outcome. There was also a fall in LH and a tremendous decrease, trend of decrease in FSH levels, which means a very important concern of HPO axis was addressed about, as pointed out by Dr. Vaheeda as well. Last but not least, the menstrual cycle and the intermenstrual intervals were also addressed about. 4 of the women also conceived during the treatment. Of course, the most important part of the study was also the adverse events. We could not see any adverse events reported to use of this particular formulation. So clinically effective as well as safe. So dear viewers, I'd like to propose EVECARE Forte for the effective management of PCOS. Of course, as our speakers have enlightened us, it will be always a combination of therapy, right from counseling to medicaments, selected medicaments, interventions that can bring about the desired outcomes. Today, EVECARE Forte is available in form of tablets and in form of liquid as well. The recommended dose is 2 to 4 teaspoonfuls twice a day for a period of at least 3 cycles, up to 6 cycles or 6 months. It can be continued later on as well, as per the need of clinical presentation there. Tablets are recommended 1 tablet twice a day for the same period. It's left to the expertise and the experience of you clinicians to take a call and to use this particular formulation and derive the benefits out of the same. With this, I'd like to conclude on my part. Before I take your leave, I'd like to extend a heartfelt thanks, a gratitude from the Himalaya Company Corporate to both of our speakers, Dr. Aruna ma'am and Dr. Vaheeda ma'am. Thank you so much for being a part of our webinar series. I'm sure our listeners enjoyed your feast of information that you've given, the experience that you've shared. It will go a long way in managing PCOS in a better manner by our speakers. I sincerely hope so. And I'd like to also take this opportunity to thank Dr. Shreyas for coordinating this for us once again, Doctor. Thank you so much. Also, our thanks. Yeah, I'd like to now take your leave. Thanks once again to each one of you, to also the viewers for sparing their time with us. Good luck to all of you. And Shreyas, all yours now, Doctor. Thank you so much for being.
Thank you. Thank you, Dr. Vaheed. Hope all our viewers viewed you and your product also. And yeah, let's wind today's session. I said we have thanked our experts and dear viewers. Our next session will be next week, and we are bringing another interesting topic. So you will have to stay tuned for that. And that topic would be abnormal uterine bleeding. And to explain about abnormal uterine bleeding, we have called 2 experts for that. And one is Dr. Mamata. So Dr. Mamata Madam, she is the professor and HOD of the prestigious SDM Ayurvedic Medical College, Udupi. She would be highlighting about the Ayurvedic concepts of abnormal uterine bleeding. And to explain about the modern counterpart of abnormal uterine bleeding, we have Dr. Pradeepa R. So Dr. Pradeepa R is an obstetrician and gynecologist at Malti Manipal Hospital and the St. Philomena's Hospital at Bengaluru also. So both these experts will be with us next week live. Till then, stay healthy and stay safe. Have a very good night, all of you. Thank you all.
Thank you, Shreyas. Dr. Shreyas, thank you very much. Thank you,
Thanks,
Dr.
thanks,
Vahid.
thanks.
And thank you, Dr. Vaheeda. Really a pleasure meeting you here. Thank you.
Thanks.
Thank you, Dr. Faiz. Thank you, Dr. Aruna. And thank you, Dr. Vahid.
Yeah.